to you all. Today's topic is on dental calculus and other predisposing factors. So previously we have learned dental plaque, that is a primary cause of gingival inflammation, and then coming to the secondary cause, that is dental calculus and other predisposing factors. Learning outcomes are: compare the distinguishing features of different types of calculus, outline the theories of calculus formation and the clinical significance of calculus, explain or point out the different modes of attachment of calculus on the tooth surface, examine the different methods of detecting and recording dental calculus which will be enabled in your treatment plan decisions. Coming to the definition of dental calculus, what is dental calculus? It is a mineralized component of dental plaque, or it can be defined as hard deposit that forms by mineralization of dental plaque and is generally covered by a layer of unmineralized dental plaque. So according to the Kern's Tenderation, it is defined as a hard deposit that forms by mineralization of dental plaque and is generally covered by a layer of unmineralized. Coming to the classification of dental calculus, it has been divided on various bases. First one, according to location, supragingival calculus and subgingival calculus. As the name indicates, supragingival calculus, which locates coronal to the gingival margin, and subgingival calculus, it is apical to the gingival margin. In the diagram, it is seen as green color. And according to the source of mineralization, it has been classified into salivary calculus and ceremal calculus. There are two sources for the mineralization of plaque. There is saliva and the ceremal or gingival trabecular fluid. So this forms salivary calculus, or it can be salivary calculus or ceremal calculus. Salivary calculus, usually the supragingival one, that you can see that this is the salivary calculus, and ceremal calculus, usually it forms the subgingival calculus. And third one, that is depending on the rate of formation, it has been classified into heavy calculus former, moderate calculus former, and slight or non-calculus former. So this removal of this plaque and calculus, it is used for the removal of gingival or reduction in gingival inflammation, and also increase in the attachment. So both supragingival and subgingival calculus may be or can be seen on radiographs. Highly calcified calculus deposits are readily seen as radiopaque projections. So coming to the differences between supragingival calculus and subgingival calculus. So this supragingival calculus and subgingival calculus, they like generally occur together, but one may be present without the other also. And this can be detected by the careful tactile perception with a delicate instrument called explorer. So coming to differences of salivary calculus, that is supragingival calculus and subgingival calculus. Under supragingival calculus, as we said before, it is seen coronal to the gingival margin. So that when it is coronal to the gingival margin, it is visible in the oral cavity. Whereas this one, that is subgingival calculus, is located apical to the crest of gingival margin, so it is not visible on the routine clinical examination. And this is present as usually white or whitish yellow in color, whereas subgingival calculus frequently appears dark brown or greenish black in color. This is hard and with clay-like consistency. The other one is hard and dense. It can be easily detached from the tooth surface. Since it is salivary calculus and it is supragingival, it can be easily be detached. And this one is firmly attached to the tooth surface. The main source of mineralization is GCF, and this usually occurs most frequently opposite to the salivary ducts. That is, we can see like buccal aspect of maxillary molars and also lingual aspect of mandibular anteriors. It is saliva from parotid duct that is a main source for buccal aspect of maxillary molars, whereas for the lower lingual side, the main source from lingual duct and the submandibular duct. Also coming to the composition of the so like supragingival calculus, concentration of calcium, magnesium, fluoride, strontium, zinc lower, and of carbonate and manganese higher, whereas concentration of calcium, magnesium, and fluoride higher, and of carbonate is lower. So mostly octacalcium phosphate and hydrocalcium phosphate as crystals are seen in supragingival calculus, whereas subgingival calculus, biglockite is mostly seen in subgingival calculus. Saliva supplies the minerals for calcification for the supragingival calculus, and this is mostly with the subgingival area where there is a periodontal pocket. Subgingival calculus can be seen. So the main source is from GCF. So coming to the composition of dental calculus, out of that inorganic components are there, organic components are there. So in this, like 70 to 90 percentage of inorganic components can be seen in dental calculus, and this inorganic components are calcium phosphate, calcium carbonate, magnesium phosphate, carbon dioxide. These are the main elements, and traces elements of sodium, zinc, strontium, bromine, copper, manganese, etc. can be seen. So the main components are calcium phosphate, that is 75.9 percentage, calcium carbonate 3.1 percentage, magnesium phosphate 4 percentage, and carbon dioxide 2 percentage. So out of this, they are seen as crystalline structures. At least 2 by 3rd of the inorganic components or inorganic part can be seen as crystalline structures. The main crystal forms are hydroxyapatite and octocalcium phosphate. So there are four main forms. Out of this, hydroxyapatite and octocalcium phosphate constitutes a bulk amount of the dental calculus. Out of this, these are mostly seen in supragingival calculus, whereas magnesium willockite and brushite are seen like in least amounts, whereas magnesium willockite is mostly seen in subgingival calculus. Brushite is mainly seen in mandibular anteriors, and magnesium willockite are mostly seen in posteriors. So coming to the organic components, so organic component of the calculus consists of a mixture of protein polysaccharide complexes, desquamated epithelial cells, leukocytes, and various types of microorganisms. And the components are between 1.9 to 9. Between 1.9 and 9.1 percentage of the organic component is carbohydrate, which consists of galactose, glucose, rhamnose, mannose, etc. And this 5.9 to 8.2 percentage of the organic component consists of like salivary proteins and include most of the amino acids, whereas lipids account for only 0.2 percentage, which constitutes neutral fats, free fatty acids, cholesterol esters, and phospholipids. So this is the composition of dental calculus, which constitutes organic and inorganic components. So coming to the attachment of calculus, there are four modes of attachment. First one, that is the attachment by organic pellicle. So it can be attached to enamel or cementum by organic pellicle. You can see that here calculus will be attached to the pellicle on the enamel and the cementum surface by mode of this attachment, that is the organic pellicle, and it can be attached to the cementum by mechanical locking into surface irregularities, close adaptation of gentle sloping of unaltered cementum surface, and penetration of calculus to the cementum. So you can see that mechanical locking into the surface irregularities. So this is a surface irregularities created on the surface of cementum. So this calculus will be attaching to that, and there will be close adaptation to the gentle sloping of unaltered cementum surface also, and you can say that penetration of calculus into the cementum. So the areas where it is got attached to the cementum, that is can be penetrated into the cementum also. These are the four modes of attachment by which calculus can be attached to enamel by enamel and the cementum. So enamel mainly by organic pellicle and cementum by organic pellicle by mechanical locking into surface irregularities, close adaptation to general sloping of unaltered cementum surface, and penetration of calculus into cementum. So coming to the important part of dental calculus, that is dental calculus formation. So dental calculus is mineralized dental plaque. The precipitation of minerals occurs in plaque between 1st and 14th day of plaque formation. The calcification itself occurs within 4 to 8 hours. So the maximum, like 50% of mineralization, it occurs by 2 days, and 60 to 90% of mineralization occurs by 12 days. And the maximum rate of formation will occurs by 10 weeks and then at least to 6 months. So it doesn't mean that all plaque doesn't necessarily undergo calcification. So the main sources of calcification are saliva and the GCF. Saliva is a primary source of mineralization for supragingival calculus, and serum transudate called GCF furnishes the minerals for subgingival calculus. The calcium concentration or content in plaque is 2 to 20 times higher than in saliva. And also the microorganisms are also not always essential in calculus formation. So coming to the details of steps of calculus formation. So for the initial mineralization process to occur, the calcium phosphate is very important, and certain membrane associated components and regulation of nuclear 5 inhibitors are also required. So for the initial mineralization, as we said, calcium phosphate supersaturation is needed for initial plaque formation. For that, this calcium and phosphorus will be taken, these minerals will be taken from saliva and GCF. So from it will be taken from saliva by chelation, and binding of this calcium ions to the complexes, that is the mixture protein carbohydrate complexes, protein polysaccharide complexes of the organic matrix, and this will lead to precipitation of the crystalline calcium phosphate salts. So these crystals will be formed in the intercellular matrix and also on the bacteria surfaces and within the bacteria. So this precipitation of crystals, this will appear as a separate foci of calcification. So it will occurs as a foci of calcification. This will be increased in size by the layer-like formation over it, and this coalesce to form solid masses. So during this calcification, the number of filamentous bacteria also increases, and this foci of calcification changes from basophilic to eosinophilic. So as we said, the scapulus will be formed in layers, and this coalesce to form a calcified mass called calculus. So the initiation of calcification and the calculus accumulation may vary from individual to individual and from location to location. So this can be categorized as heavy, moderate, or slight. That is why it doesn't mean that all calculus should go, all plaque should go for mineralization. So that is why it is different from like side to side. And the average daily increment in calculus formation is from 0.10% to 0.15% of dry weight calculus. So this is the steps for the formation of calculus. So coming to the theories of calculus formation. So coming to the theories regarding the mineralization of calculus, mainly there are two theories which leads to the precipitation of that is formation of calculus. There is precipitation theory and the epidactic concept or heterogeneous nucleation. Under that precipitation theory, that is the precipitation of calcium phosphate ions. So when there is increased rise of degree of saturation of calcium and phosphate ions, there will be precipitation of calcium phosphate ions in the crystal forms. That is mainly due to increase in pH of saliva, colloidal proteins in saliva, and also the enzymes present in saliva. The first one, that is increase in pH of saliva, that is when there is that is loss of carbon dioxide and ammonium formation in plaque or protein denaturation. What happens, there will be increased pH of saliva. So when there is increased pH of saliva, which increases the precipitation of calcium salts from saliva. So there is a first mechanism. The second one is there is a colloidal proteins in saliva which precipitates the calcium and phosphate ions, which happens with the stagnation of saliva, and also the colloidal proteins when they get settle out. So that is which leads to the precipitation of calcium and phosphate ions. The third one is that is by the phosphatase and esterase. Phosphatase, what it does, that is this is present in the plaque, bacteria, and discontinuous epithelial cells present in saliva, which precipitates the calcium phosphate by hydrolyzing organic phosphates in saliva. So this phosphatase, that enzymes which precipitates the calcium phosphate by hydrolyzing the organic phosphates in saliva. And this esterase which initiate calcification by hydrolyzing fatty esters into free fatty acids, which forms salts with calcium and magnesium ions, and which leads to the precipitation of calcium and calcium phosphate salts. So these are the three mechanisms. First one, increasing pH of saliva, colloidal proteins, and the enzymes like phosphatase and esterase. Phosphatase, which precipitates by hydrolyzing organic phosphates, and this one which initiates calcification by hydrolyzing fatty esters into free fatty acids, and which forms salts with this. So by this, which will precipitate the calcium and phosphate salts. So coming to the next theory, that is the epitactic concept. That is here, as we said before, so this will be taking this salivary proteins, that is calcium from saliva by chelation. This uh, this calcium hydrate and protein complex is present in saliva, so which acts as a seeding agent, so which will induce a small foci of calcification, small nuclei of calcification, so which get enlarges and by layer formation, which will get enlarged and coalesce to form calcified masses. So this is the second periodic concept of heterogeneous population. So coming to the role of microorganisms in the mineralizations calculus, that is, we have already told that it is not necessary this microorganism should be present for the formation of calculus, and also we have found that there are several organisms that are associated with the formation of calculus. There is filamentous organisms, diphtherioids and bacterionema and virulina species have the ability to form intercellular aggregate crystals. Mineralization spreads until the matrix and the bacteria are calcified. So they may actively participate in the mineralization calculus by forming phosphatases, which changes the pH of the plaque and induces the mineralization. So these are the role of microorganisms in the mineralization of, these are the main organisms that are associated with the mineralization of calculus, and also this by the formation of phosphatases, this enzyme which leads to the precipitation of minerals. So coming to the next part of the class, that is other predisposing factors. Under that we would be discussing iatrogenic factors. The first one, iatrogenic factors. What are iatrogenic factors? Inadequate dental procedures that contribute to deterioration of periodontal tissues are called as iatrogenic factors. Under that, margins of restoration. Margins of restoration, there is subgingival margins, that is always, or overhanging margins, that is always contribute to the development of periodontal disease by changing the collic knife and also by inhibiting the patient's access to remove the accumulated plaque. So this subgingival margins is always associated with large amounts of plaque and the gingival inflammation. You can see in this picture that is subgingival margins. It is like it is causing the gingival inflammation. So margins placed at the level of gingival crust is which induces less inflammation compared to subgingival margins. And coming to the over condos or open condyles, over condos is always associated with the inhibition of patient's oral hygiene maintenance. So, and also this open contacts between the spacing also, which leads to food impaction, and finally leading to the gingival inflammation and periodontitis. And coming to the like uh, that is dentures, that is fixed bridges or removable partial dentures. So access for oral hygiene will be inhibited with excessive pondic tissue contact also. This will contribute to plaque accumulation and finally formation of pseudo pockets. With the design of removable partial dentures, they are like partial dentures are worn during both day and night, which induce plaque formation than those worn only during the daytime. And also the presence of removable partial dentures not only causes the quantitative changes, and also it related to the qualitative changes also. So these are the iatrogenic factors, main iatrogenic factors when we talk about the restorative parts. And coming to the occlusion, there is orthodontic a department, that is the factors are malocclusion, there is malalignment, crowding always contributes to the food accumulation and the inadequate oral hygiene maintenance, and also periodontal complications associated with orthodontic therapy, that is with excessive forces applied by the orthodontic treatment will be always detrimental to the periodontal health, which would be like causing the bone height and causing the periodontitis. If there is local factor associated with it, this will be aggravating the factor and leading to periodontitis. And plaque retention and composition, that is the orthodontic uh, wires brackets therapy will be hampering the plaque accumulation and the retention, thereby like poor oral hygiene maintenance. And also gingival trauma and alveolar bone height, there is forceful attachment of the bands, orthodontic bands will always like interfere with the alveolar bone height. So coming to the extraction of impacted third molars, so the numerous studies have reported that the extraction of impacted third molars can result in the creation of vertical defects to the second molars, and habits and self-inflicted injuries like trauma associated with oral jewelry, toothbrush trauma, chemical irritation, this can all can affect on the gingiva. You can see that this trauma associated with the oral surgery, this can impinge on the like lingual side of mandibular anteriors and cause bone loss. The toothbrush trauma that can be associated with this, that is which leads to the inflammation of gingiva or traumatize the gingiva. Then chemical irritation, that is by chemical burns due to some acidic foods can also related to these injuries. And smokeless tobacco, that is smokeless tobacco like chewing tobacco, is also like can affect on the gingiva, that is which will be usually placed on the mandibular buccal vestibule for several hours, so this can have effect on the periodontium. Then radiation therapy, as we said, that it can affect on the malignant cells and also as well as on the normal cells also, so like that it can be affected. And also this radiation therapy will lead to dryness of mouth, so which will lead to the oral hygiene maintenance also. So this will lead to the gingival inflammation and the effect on periodontium. So these are the predisposing factors. So coming to the conclusion, dental calculus represents mineralized bacterial plaque. It is always covered by unmineralized viable bacterial plaque, and hence it does not come in contact with gingival tissue. Calculus, therefore, it is a secondary etiological factor for periodontitis. Its presence, however, makes adequate plaque removal impossible and prevents patients from performing proper plaque control. It is a most prominent plaque retentive factor which has to be removed as a basis for adequate periodontal therapy and prophylactic activities.